S1 occurs due to the closure of the mitral and tricuspid valves at the beginning of systole, and at the end of systole, S2 is produced, which is due to the closure of the aortic and pulmonary valves. This cycle repeats itself. That is, after S2, S1 occurs again. To distinguish S1 from S2, we need to place the stethoscope on the patient's heart and at the same time place our opposite hand on the carotid pulse. The sound that is heard simultaneously with the start of the carotid pulse is S1, and the sound that is heard at the end of the carotid pulse is S2. The next point is that the first heart sound, or S1, is better heard at the apex because it is caused by the closure of the mitral and tricuspid valves, and it is a stronger sound. Whereas S2 is heard louder than S1 at the base of the heart, that is, in the second intercostal space on the right and left sides. The next point is that the S1 sound has two components, M1 and T1. M1 is due to the closure of the mitral valve, and T1 is due to the closure of the tricuspid valve. M1 is louder than T1 because the pressure in the left ventricle is higher. The pressure in the left ventricle during systole is 120 millimeters of mercury, while the pressure in the right ventricle during systole is 20 millimeters of mercury. That's why the closure of the mitral valve is more forceful, and the M1 sound is heard louder than the T1 sound. That's why M1 can be heard throughout the entire chest, while T1 is only heard at the NSV and PIGAS. What factors affect the intensity of the S1 sound? The first factor is distance. The farther the stethoscope is from the heart, the weaker the S1 sound becomes. Conditions such as COPD, asthma, emphysema, pericardial effusion, or obesity increase the distance between the stethoscope and the heart. Therefore, the intensity of S1 decreases. The second factor is the PR interval. The longer the interval between P and QRS, the weaker the S1 sound becomes. Because, as you know, when the PR interval is prolonged, it causes the mitral valve to open. And since the left ventricle hasn't contracted yet, the valves go from being fully open to partially closed. And when they close from a partially open position, they produce less sound. It's like a door that is completely open. When the door is fully open, when you push it and close it, it makes a louder sound, compared to when the door is half closed, meaning it's at a 45-degree angle, and then you close it. That produces less sound. Therefore, in patients with a short PR interval, the S1 sound is louder. But in patients with a prolonged PR interval or those with first-degree AV block, the S1 sound is diminished. By the same mechanism, in patients with acute severe A1, the S1 sound is reduced, because the jet of aortic insufficiency causes the mitral valve to remain in a semi-closed position. The third factor is the mobility of the mitral valve. In patients with mild and moderate mitral stenosis, because the mitral valve has thickened, the heart sounds resulting from it, that is the S1 sound, are also increased. But in a patient with severe mitral stenosis, due to calcification and fixation of the mitral valve, no sound is produced anymore. Therefore, the S1 sound decreases in severe MS. The fourth factor is the state of left ventricular contraction. The greater the LV contractility, the louder the S1 sound will be heard. That is why in patients who are in a hyperdynamic state, such as those with hyperthyroidism, pregnancy, anemia, or after exercising, the S1 sound increases. Conversely, in patients who are in a hypodynamic state, such as those with heart failure, those who have taken beta blockers or following hypothyroidism, the S1 sound decreases. The next point concerns patients who have variation in the S1 sound. We see this condition in patients with irregular heartbeats, such as those with atrial fibrillation and patients with complete heart block. As we mentioned, S1 has two components, M1 and T1. M1 is caused by the closure of the mitral valve, and T1 is due to the closure of the tricuspid valve, which usually happens simultaneously. But in some conditions, such as right bundle branch block, or in patients with ASD, the closure of the tricuspid valve occurs with a delay. That's why M1 becomes separated from T1, resulting in S1 splitting. So how do we actually hear the S1 and S2 heart sounds? We hear S1 as a lub and S2 as a dub. That is lub-dub, or loop-doop, loop-doop. Or we could even articulate it as 1, 2, 1, 2, 1, 2.